Okay, students, we are still working on Chapter 9, Schizophrenia, and now we're going to be moving on to Segment 2, spending some time talking about the etiology of schizophrenia. Slide 14. So this table here looks at some of the characteristics of adopted offspring of mothers with schizophrenia. There's been a lot of research done looking at the genetic components of schizophrenia. This study from Denmark tracks the relationship between parents and children. Of course, we have to consider environment. When both parents had schizophrenia, the incidence of schizophrenia in that child hovered right around 27%. When one parent had schizophrenia, it hovered around 7%. When neither parent had schizophrenia, it was less than 1%. Adoption studies help us to try to look at the impact of environment. And so what we're looking at is the children of schizophrenics who are raised in an adoptive home. In one study that looked specifically at whether or not the mother was schizophrenic, that study found that about 10% of those children who were raised in an adoptive home developed schizophrenia compared to none in the control or the comparison group. We've done a lot of familial studies when it comes to schizophrenia. In other words, looking at how this trait or how this disease runs through families. And what we do is we follow the offspring of children of schizophrenics longitudinally. In other words, we're following them through time. We're following them from early childhood all the way into adulthood. And we find that these children, the children of schizophrenics, are 6 times more likely to develop schizophrenia by the time they reach age 40. Slide 15. So we see a lot of genetic support, that there is some sort of genetic component to schizophrenia. This table clearly indicates that those who are related to an individual with schizophrenia are at an increased risk. As the genetic relationship gets closer, the risk increases. So if we look at a spouse, it hovers right around 1%. But when we're looking at monozygotic twins, and these are twins, they are identical twins that share 100% of their genes, that hovers right around 44%. The more genetic overlap we have, the closer individuals are related genetically, the more likely we are to see the appearance of schizophrenia. We also know that the negative symptoms of schizophrenia seem to have a stronger genetic component. That being said, we do know that schizophrenia has to be genetically heterogeneous. It's not likely that the disorder is caused by one single gene. So let's go back and take a look at these twin studies, these monozygotic twins. So when we compare monozygotic twins, which are identical twins and share 100% of their genes, to dizygotic twins, which are just like regular sibs, we see 12% in comparison to 44%. So we see a very strong genetic link. But keep in mind, though 44% indicates a strong genetic relationship, it's not 100%. We know that environment still must play some sort of role here. Slide 16. So if we know that it has to be more than one gene, or maybe even multiple genes are involved, what we do is we conduct association studies. And association studies try to look at how often a specific gene is connected to a particular trait. We do know that DTNGP1, that gene seems to be associated with schizophrenia. DTNGP1 is connected to dopamine, and this neurotransmitter seems to have a strong relationship to schizophrenia, and we're going to talk about that relationship in more detail a little bit later. We also know that there are 2 other genes that are associated with the cognitive deficits that we see with schizophrenics, COMT and BDNF. Both of them seem to be connected or somehow related to the cognitive deficits that are associated with schizophrenia. It's important to point out, though, that it's been very difficult to replicate this research on these genes. And it really points to the genetic heterogeneity that's connected with the development of schizophrenia. So what we've tried to do to sort of answer that question is conduct genome-wide scans. So what we're trying to do now with these genome-wide scans is identify genetic mutations. And several have been identified, but again, the results need to be replicated. We need to see some consistency in these studies across time. Genetic mutations can happen for a variety of reasons. And once that genetic mutation is identified, we have to be able to connect it to schizophrenia. So for example, one genetic mutation identified promoted the proper placement of neurons in the brain during development. Other genetic mutations, we've got a whole new slew of research being done on sperm, because now at this point in history we're able to look at sperm and the genes that a sperm carries in much more detail than we ever could before. And we're finding that the sperm in men steadily increases. The genetic mutation in sperm steadily increases as men age. What's interesting, though, is though we know or we suspect that there's some sort of connection between genetic mutations and schizophrenia, only about 20% of schizophrenics seem to carry any genetic mutations. So using this tool to explain is very limited. Slide 17. We do know that neurotransmitters are involved in schizophrenia, particularly dopamine. The dopamine theory looks at the excessive levels of dopamine in the brain and its connection to schizophrenia. We do know that drugs that alleviate symptoms reduce dopamine activity, and things like amphetamines, which increase dopamine levels, can induce psychosis. Dopamine is also related to Parkinson's. People with Parkinson's do not have enough dopamine, and that leads to the shaky or jerky behavior. And when you introduce dopamine, what happens is that they can have very vivid dreams and even hallucinations. Many clinicians and researchers feel very comfortable with antipsychotic drugs that reduce dopamine, and we know that they work to reduce the symptoms of schizophrenia. However, the theory has been revised. We know that it's just too simplistic, and there's probably more related to schizophrenia. We're thinking now it may be excessive numbers of dopamine receptors or oversensitive dopamine receptors, that individuals with schizophrenia just simply have too many dopamine receptors, or their dopamine receptors are very sensitive and pick up dopamine very easily. We know that there's a lot of localization mainly in the mesolimbic pathway. Mesolimbic dopamine abnormalities are mainly related to positive symptoms, and that there's actually underactive dopamine activity in the mesocortical pathways, which are mainly related to the negative symptoms. So in other words, dopamine neurons are underactive in the prefrontal cortex, so they're unable to control for the overactive neurons that are in the subcortical brain. The subcortical brain contains things like the amygdala, which houses all that emotional memory. So if we go to this figure here and take a look, what we're having is lots of dopamine activity here in the mesolimbic pathway. When it gets to the frontal lobe, there's not enough dopamine or neural activity to counteract what's going in the mesolimbic pathway. Slide 19. And there's a fair amount of support for this. This figure here basically lays out the dopamine theory of schizophrenia. And we know that there's support for this because the meds don't seem to impact the prefrontal cortex. And because the prefrontal cortex, because the meds don't seem to impact the prefrontal cortex, the medications don't seem to have any impact or effect against the negative symptoms of schizophrenia. Slide 20. So as we continue to evaluate the dopamine theory, we know that it doesn't completely explain the disorders. The antipsychotics block dopamine rapidly, but the symptom relief can take several weeks. And to be effective, the antipsychotics must really reduce the dopamine activity to below normal levels. It's a very complex disorder. We don't fully understand how the medications work, and there's probably more than one neurotransmitter involved. Remember, neurotransmitters are those chemicals that neurons produce to help them communicate with each other. Other neurotransmitters that might be involved might include serotonin, GABA, and glutamate. And we do know that medications that target glutamate do show promise in the treatment of schizophrenia. Slide 21. Another potential theory to explain schizophrenia looks at brain structure and function, particularly at enlarged ventricles. This has been done in postmortem studies. Postmortem studies are dissections that happen after the individual dies. The brain has 4 ventricles that are filled with cerebrospinal fluid. When they are large, it implies the loss of brain cells. This loss of brain cells is correlated with poor performance on cognitive tests, poor premorbid adjustment, and poor response to treatment. We're fairly sure this is not caused by medication, and we pretty consistently see these enlarged ventricles in individuals that have schizophrenia. However, large ventricles are not exclusive to individuals with schizophrenia. Other disorders like bipolar also have large ventricles. And some individuals have large ventricles and don't have any mental health issues at all. Other brain structure issues that we look at include the prefrontal cortex. We know that many behaviors are disrupted by schizophrenia. Remember, your prefrontal cortex controls things like speech, decision-making, memory. Individuals with schizophrenia, they show a lot of impairment in the neuropsychological tests of the prefrontal cortex. MRIs indicate that there is a reduction in gray matter volume in individuals that have schizophrenia. Research done with PET scans show low metabolic rates, and this seems to be related to the negative symptoms. And we also see a disrupted communication among neurons due to loss of dendritic spines. This is also known as disconnected syndrome. And again, it may be related to genes, but we do know that these are structural issues that we're seeing in the prefrontal cortex with individuals that are struggling with schizophrenia. Slide 23. Other structural issues include structural and functional abnormalities in the temporal cortex. Now remember, those temporal lobes, they're at the side of the brain, they're located by the ears, they are primarily responsible and govern hearing perception. Structures that are in the temporal lobe include the temporal gyrus, the hippocampus, the amygdala, the anterior cingulate. We see reduced gray matter and volume evident in individuals with schizophrenia, and also disrupted connectivity in the brain. And we also see smaller hippocampus volumes. Remember, the hippocampus helps us to learn. The amygdala is responsible for emotional memory. Slide 24. Could there be any environmental factors that have impacted brain structure? We do know that damage during gestation or birth, such as delivery complications, there's a fairly high rate of delivery complications in patients with schizophrenia. A reduced supply of oxygen during delivery may result in a loss of cortical matter. There is also research that indicates there might be viral damage to the fetal brain. A couple different studies. One looks at the presence of a parasite called Toxoplasma gondii. This is associated with a 2.5 times greater risk of developing schizophrenia. Yet I want to point out here that this particular parasite, a lot of people carry it on their bodies and don't show any signs of schizophrenia, don't seem to be impacted by the parasite. In another Finnish study that looked at the great influenza epidemic of 1957, schizophrenia rates were higher when the mother had flu or was exposed to flu in the second trimester of pregnancy. Yet, what's very challenging with these viral studies is that they're hard to replicate. And the question is that if there's a virus that's impacting the brain so early in life, why do we see the onset of the disease in late adolescence? Slide 25. And the answer to that question may lie in developmental factors. Really, the prefrontal cortex doesn't mature until adolescence or early adulthood, and that's when the dopamine activity seems to peak out. Stress activates the HPA system, which we talked about earlier in the semester. This is going to trigger cortisol secretion. The higher stress levels, the more cortisol a person produces. The more cortisol that person produces, that's going to increase their dopamine activity. There might be excessive pruning of synaptic connections. I want to spend a minute talking about this. Neural pruning basically happens at 2 times in life. The first time that it happens is right around the age of 2, where that brain sort of prunes or pulls out those neural connections that aren't really being used anymore. And then a second pruning seems to happen right around puberty. And maybe this second pruning is simply ineffective. It's either excessive or the wrong neurons are being pruned, or there's just not enough being pruned. Another factor that might correlate is the use of cannabis during adolescence. The use of marijuana during adolescence is also associated with increased risk. Again, the adolescent brain is a developing brain, and the use of illicit drugs can have an impact on that development. Now, that being said, the relationship's not clear. Is the marijuana causing the schizophrenia, or rather, do individuals use drugs in order to cope with the symptoms of schizophrenia? It's possible that the use of illicit drugs or the use of cannabis might be a gene-environment interaction, where that person, it may be genetically set up, the use of the substance then sort of pushes them over the edge and they get the symptoms of schizophrenia. These developmental factors may explain why symptoms appear late in life, later in adolescence, even though the damage occurs earlier. Slide 26. Psychological stress. We know that individuals with schizophrenia seem to be very reactive to stress. Research looking at schizophrenics and their families find that they and also their first-degree relatives are very sensitive to stress. They are vulnerable to life stressors along with everyday stress. Those of us who work with college students, those of us who teach at the college level, we know the first 2 years of college are a time when we see a lot of onset of mental health issues. And that's because going away to school causes 2 things. Number 1, the loss of various safety nets. And the second thing, an increase in personal responsibility and stress. And all that seems to add up to be a sort of tipping point for young adults. And we do see a increase or an uptick of mental health issues. Individuals are 18, 19, 20. Socioeconomic status can also impact because we do see our highest rates of schizophrenia among urban poor. Now, why might that be? It might be a sociogenic hypothesis, the stress of poverty causes the disorder, or it might be social selection theory, where there's basically downward drift in socioeconomic status. When the person develops the mental health issue, they cannot maintain work, they can't maintain a job, they can't continue on in school, so they drift downward economically. Research seems to support social selection. Slide 27. What about family factors? Do they play any role? There used to be a sort of an old theory called the schizophrenogenic mother, this sort of cold, domineering, conflict-inducing mother that created schizophrenia in their child. There's really no support for this theory now. And also communication deviance. Is there a lot of hostility in the home, poor communication? And that's also inconclusive at this time. Slide 28. So when we think about hostility in the home, or we think about poor communication in the home, it's not clear that that would cause schizophrenia. But we do know that family environment can impact relapse. So when we look at something like expressed emotion, that's the rate of hostility, critical comments, or emotional over-involvement that's expressed in a household. That can have an impact on relapse. We think there's some sort of bidirectional association. In other words, if the person behaves unusually or if they're expressing unusual thoughts, that can increase the critical comments or the hostility from family members. But also these increased critical comments or hostility from family members can turn around and increase unusual patient thoughts or behaviors. When someone who's struggling with schizophrenia returns to a home that has low hostility or low expressed emotion, only about 10% of them relapse. But those individuals that return to homes that have high hostility or high expressed emotion, about 58% of those individuals relapse, go back into an acute state of schizophrenia. Slide 29. An interesting developmental study that's been done is called a follow-back study. So in other words, when you have an adult that's been diagnosed with schizophrenia, what you do is then you go back, you follow back. You talk to parents, you look at what you know about them from their childhood to see if there were any clues that might have led to them becoming schizophrenic. And what these follow-back studies are really doing is they're looking at developmental histories of children who later on develop the schizophrenia. Couple variables that we see pretty consistently are lower IQ, delinquency in boys, and being withdrawn in girls. Super studies that was done, very interesting study that was done, looked at home movies, coded home movies. And what they found were that the adults who had schizophrenia, when they were children in these home movies, expressed poor motor skills and had much higher rates of negative emotion. Slide 30. Other developmental studies include a very interesting New Zealand study that looked at cognitive deficits. Basically, cognitive and IQ assessments were administered at various points throughout development, from 7 to 32. And what the researchers saw were lower IQs and cognitive deficits. Those emerged at around the age of 7 and stayed stable throughout adolescence. In an Australia study, it's considered a clinical high-risk study. It's done because it's difficult at collecting large sample sizes. So what you do is you go to clinical settings and you actually look at those individuals. And what we found in this Australian study, it followed individuals between the ages of 14 to 30 who had been referred over to them by a mental health clinic, and found that these individuals had reduced gray matter volume, and that went ahead and predicted later development of psychotic disorders. A North American prodrome longitudinal study identified factors associated with development of psychosis, and the three main factors that I want you guys to take away from this are things like having a biological relative with schizophrenia, decline in functioning, particularly cognitive functioning, and having a high level of the positive symptoms are all associated and connected with the later on development of schizophrenia.